So what we'll do is we've got these two simultaneous cases going on. I want to send you back to Matul when he's doing the stenting. So what we're going to do is Rodrigo. So let me reintroduce our team. We have the same team. Rodrigo MENDIRICHAGA, our fellow. Lauren Sang is behind me. Tomas is our tech at the table. And if we just swing over to Brandon, Ashley, and now we have, where's Christy? We have Christy, our runner, in the back. And we also have Patty. So we've got same team, minus one person. We changed to Christy to get our equipment. What we'll do is Rodrigo will introduce this case. It's a pretty complex case. I want to talk about where we are with it right now. And then we'll do some aspects of it now, and then we'll go back to Dr. Patel. Rodrigo is going to give us a quick intro.
Great. Welcome back, everybody. So this is a case of complete revascularization with hemodynamic support and robotic assistance. Next slide, please. So this lady's 58 years old. She presented with stable angina and a cardiomyopathy with an EF of 40%. EKG showed no ischemic findings. Like I said, her EF was 40% with normal RV function. Her EF had actually improved from 17 to 40% with medical therapy in the past month before getting her catheterization. Current medications include amlodipine, aspirin, atorvastatin, carvedilol, furosemide, and Entresto. Her baseline creatinine is 0.7. Next slide, please. So she presented to the cath lab for a catheterization and was found to have this distal left main bifurcation disease with a Medina 111. There's also kind of a 50% mid-circ into the OM. Next slide, please. Another picture, we can also see these distal left main bifurcation disease and also diffusely narrowed mid to distal LAD. Next slide, please. Her RCA also had this mid-vessel severe lesion. Next slide, please. So in summary, she's 58, stable angina with a cardiomyopathy, EF 40%, a complex anatomy with a syntax score of 31. And the plan, after discussing with the surgeons and with the patient and having a heart team meeting, is to undergo PCI due to a poor lima target on that diffusely narrowed mid to distal LAD and also patient preference. So she was loaded with ticagrelor and presented to the lab today.
All right.
Shami, your hospital is full of Protect 4 patients.
Can you believe it? So
Eugenics.
here's another Protect 4 patient. And let me start by showing you the femoral angiogram. So we did this femoral angiogram. It's a large femoral artery. We went ahead and placed an Impella CP. You can see the placement here. This is a single access approach. So through that single access, which at some point we'll show you what that looks like when we come back into the room, we've got a guide catheter engaged the right coronary artery. As you noted from Rodrigo's initial images, the mid-right's tight, the distal left main bifurcation is tight. Lima LAD was a poor target, which was the reason that we're doing this percutaneously. So we're going to start off by doing the right, then we'll go to Dr. Patel, and when you come back, we'll work on the left main. So hemodynamic support in place. We're using bivalirudin for anticoagulation, and we have ticagrelor preload 2 days ago.
Correct.
So once again, this controls my balloon, this controls my guide wire, this controls my guide catheter, and we're engaged, and I'm coming down the right coronary artery. We've given some nitro already. I want to show you what this looks like when I'm bringing the wire down. I'm going to put the technique or ROR on, and what that does is it redirects the wire as I need to do that. Give me a puff, please. So it goes into that marginal branch. I bring it back. And I don't know if you saw that. I just bring the wire back, advance it. It automatically rotates the wire out of that lesion, out of that side branch. So now we're at the second branch, the tight lesion. So Rajiv, looks like I can still do this. Give me a puff. So we're in a RV marginal. So I'm going to come back.
Dr. Mahmoud, even a blind squirrel finds a nut sometimes.
Yeah. It's good to have friends on the panel. And as they say, with friends like this, who needs enemies? Puff again. All right, so that wire is now down in the distal right. I'm going to bring my balloon down. So here's the pre-dill balloon coming down to that mid lesion. Hook up and go negative, please.
We're hooked up.
Ready.
Negative.
Okay, go up.
Going up.
2015 balloon.
So we have the 2015 mid RCA balloon. Go up to 14 atmospheres.
14.
16.
16.
Down. Remember I told you guys earlier, I wanted to show you how to measure lesion length with this. If we take a look, give me a puff. So it looks like we're diseased from right about where the distal marker is. So I'm going to zero this. And I don't know, can the camera focus on this, please? So now we're looking at a zero measurement. Distal marker, I'm bringing the balloon back. All the part to where the vessel starts to dilate up to a larger size. Puff. That's about where I want the stent to end up. It measures 47 millimeters, so it tells me we need 2 stents. So I'm going to pull that balloon out. We'll take a 275/38 synergy, please.
Marker.
So let me show all of you, what do you think? Looking at that right coronary, would most of you want to treat the entire mid-segment back to the prox or just focally treat the mid-right?
Doesn't look like you need to do the prox there from this view. Depends on how far you're talking.
Yeah, so Bill, if you, obviously the mid vessel is very tight. And beyond that, at the hinge point, there's a lesion. So I want to go beyond that hinge point. And then when we come back, the question is, the first, say, 2 centimeters of the prox right look large, and then it tapers off. So why don't we put the 275/38 stent, and then we'll see what the proximal segment looks like or whether or not we need to put a second stent.
Sammy, when you get the Megatron, it'd be great. You need 1 stent. You should be done with the whole thing.
One long stent and be done with it. Well, we're going to do this mid-right, and let's see what that looks like. I wanted to kind of show that first case ended up being more complicated and complex for the robot system than I anticipated, but you can see here how quickly and with what easy facility we can wire the right coronary, and we just pre-dilated with the 2015, and now we're going in with the stent.
Would anybody protect the side branch, put a wire there just for protection? It's a large branch, supplies also some of the inferior side.
Good question, Gira. I'm not sure I've ever really saved these, but you're right, it's more than just a marginal, isn't it? It extends all the way over.
Yeah, to that distal PDA territory.
I've never done it.
This is Dan Walters. I certainly don't think that's a interventional target for bifurcation intervention, but if it does go down or have slow flow, you could always have that wire and protect it, take a second wire in and balloon the os.
Let me think about it for about 4 minutes.
We'll see how it looks after you deploy.
All right, so here we go. I'm going to enable. The stent has been loaded in. And so the wire's in place, guide's in place. Here we come down with the stent. And if you look at my left index finger, this makes the stent traverse through the guide catheter much more rapidly. But once you're in the coronary, you really don't want to do that. So I'm slowly advancing the stent just like I would do manually. So guys, hook up and go negative.
Negative.
All right, give me a good puff. I like that spot. Let's go up.
Going up.
2, 4, 6,
2, 4, 6,
8, 10, 12,
10, 12,
14,
14,
16,
16,
18.
18.
Down. Okay, you ready for a picture?
Ready.
So I think my Synergy stent is a little undersized. So I'm going to expand that to be a little larger, and I do want to put another stent at the prox edge. So we're going to go with, let's see, any takers in the audience
I would do
or
a three-
panelists? What do you
I would
guys
do a
think?
3-5, 24, 20 or 24 Synergy, and then use that balloon to pulse dilate the distal.
I like that, Rajiv. So that
You know
one
how to
in
save.
there is,
But stay away from the
so
osteo,
this
right?
one in the, this is a 38. So 20 or 24? I'm going to go with the 24. 3-5, 24 Synergy.
You see already much better perfusion of the distal right coronary. This blush that we have not seen before.
Yeah, and I think this is a time to kind of talk a little bit about the initial overall strategy. And as Tim pointed out, you know, just today, you see these multiple patients who would be candidates for Protect 4. This patient actually had an EF that was 20% just a month ago, and she was started on optimal medical therapy. The CATs revealed pretty severe disease, and our goal is that that EF should improve even further once we get the left main revascularized and we've got this right coronary revascularized.
I don't recall, was she a diabetic?
She is not a diabetic.
Okay. Even if she were diabetic, I think this highlights a good case where there is enough equipoise between bypass and stenting with an intermediate syntax score, but most of the disease in the proximal left-sided vasculature very, very focal in the main. So that if you do have in-stent restenosis, which would be a major concern with the diabetic patient, that's especially this young, there still are very good bypass targets down the road if she were to require that.
Yeah, so Dan, that's a really good point. This is going to be mostly the left main into prox LAD stenting and circ stenting. We're not going to go into the rest of the LAD. But I will tell you, if this had been a 3.0, 3.5 great target for the Lima, I don't think I would have been as apt to treat this patient percutaneously. But there was a combination of patient preference and poor targets that made the decision a little easier.
Their
Marco?
preference always matters, and in this case, her preference was the correct preference.
All right, so here we go with the 3.5/24.
But it does bring up a good point, though, is if a patient says he or she wants PCI, and you believe that the patient is a better candidate for surgery,
Hook up and go
what do you
negative.
do?
Negative.
Tim, what do you do?
Fluoro flavor 3.
Well, I think if it's truly equipoise, if I'm
me a
really on
puff.
the fence, I would, listen to what they do. But, I think, obviously, I'm a little more biased
again?
towards PCI. But one of the things I take care of a lot of refractory angina patients where 80+% of them have had previous bypass, and I see the other consequences of bypass, right?
Hey guys, we're
think
going to
about
cine. Ready?
pleural effusions, chronic edema, atrial fibrillation.
Probably come back some
Well,
of
I
that.
usually say at least talk to the surgeon, if I feel that really needs to be maintained. And
I think
sometimes,
that's a very good point. Make sure they meet a surgeon before they make a no decision. If you feel strongly that surgery may be their best therapeutic option.
yeah, sometimes their concerns are not really as valid as, or are not based in actual.
Puff again?
I mean, there are definitely high syntax score patients who I think it would be wrong to do PCI, who really want to get PCI, who I convinced not to
Puff?
get PCI.
And I think Dr. Patel's made a good point of this before. For some of our patients, they
Puff?
seem prone to choosing PCI because it's, in their mind, a same-day in-and-out procedure.
Hey, she's sort of
and
digging
that's
a
what
lot of
they're
deep
favoring.
breaths, huh?
And, bypass is a
One more
extreme
puff?
undertaking, but it's one that if there's
I
strong
think
benefit
this.
for, we
I
really
think you're
push it for
overlapped by
patients.
a few.
Yeah, no, it's a good spot right there.
Looks great.
Ready to go up and go deploy it? And I'm
Yep,
going to
we're
pull
ready
the guide
once
once you're up a couple of atmospheres. Go
Yeah.
ahead.
Going up.
Go to
It's definitely
16,
an issue
and
for
now
me. I mean, I have a very
16.
difficult time understanding what to do in that situation when a patient says, I want PCI.
Yeah.
I believe the patient should get surgery. You know, drive-by PCI doesn't work, obviously. You take them off the table, you have heart team approach. But even then, if they're still insistent on PCI, but the surgeon says he can do the surgery, do you still do PCI?
You cannot
16.
force the patient to have surgery if the patient does not want surgery,
I'm
right? You
definitely
can
not.
convince,
Definitely not.
we can tell the patient, I'm sure we all had those situations, telling
Yeah.
the patient, we think we'll get better results. There are some of
Go
the
to flow
blockages, we
flavor two.
cannot put stents, there will be partial revascularization, not complete revascularization. But we cannot force, right? There's informed consent here.
100%. I had an attending who used to walk up to the patient and say, I can either fix you and you'll be home in 6 hours, or you can crack your chest open.
Go up.
8.
Yeah, some people think it may make no sense to take a sick patient and to open her chest, right? But sometimes it's better for the patient for the long term, so we need to accept that.
Okay?
Shami, did you
16
think
and
about
down.
imaging here?
16 down.
I'm going to image the left side. I really didn't. I think if I'm feel that this is a suboptimal angiographic result, or if I'm going to go bigger than 3.5, then I might. That's a good point.
Tell us
Especially
about
after
your
Ziad's
thoughts on
lecture.
post-dill with the stent balloon, like you're doing here.
I think as long as I can get it there, I like it. Okay, go up again, guys.
Going up.
But it's
And 12,
14.
14.
Those balloons, compliance is something in between
Yeah.
the semi-compliant and the compliant balloons, and in simple situation like that, I think there's no reason why not to do it. I think, Rajiv, that was a great idea.
Yeah, go up one more time. We're
And
right
saves,
at the
and
distal
saves
edge.
money.
14, 16,
16.
and down. So what we're going to do is we're going to pull this back. We'll take a picture. And then we'll make a decision about whether we need to image or we need to use a bigger balloon to further optimize or do any additional imaging. Ready for a picture?
Ready?
Okay, what does my panel think?
It looks beautiful angiographically.
Okay, so what we're going to do is I'm actually going to go up another half size, 375/15 NC emerge, and then we're going to switch over to the left side and take care of that. So why don't I send you back to Dr. Patel, and you can see what's going on in that room, and when you come back here, we're going to be working on the left main.
Hi, Shemi.
Hey,
We're
that
behind,
looked
we're
amazing.
behind your back now.
You
Okay,
got lead
Jewel
on.
did a
I didn't
great
think you
job.
wore lead anymore.
No, well, come on, Tim, I gotta work once in a blue moon. Okay, so let's look at the angio films here, and I'll show you where we left you guys. This was at 3.5/24, and this is what the angio looked like after the 3.5 stent balloon to post-dilate. I didn't like that, so went with the 3.75, non-compliant up and down, and that's our right. So looked a lot better. So then we flipped over. Here's the guide in, you can see the distal left main, and you can hopefully see it better. It extends into the LAD and the circumflex. So we wired both, and we have a 2.5/15 balloon in the circ, 2.5/15 in the LAD, and then we went ahead and IVUSed. So we're going to show you the IVUS of the circumflex and the IVUS of the LAD.
Hey, Rodrigo, why don't you play the first run? This is the first run from the circumflex back to the left main. You'll see some the disease of the left main approaching right there. The minimal luminal area of that is 4.5. Rodrigo, why don't you click on the bookmark B1? So here with the measurements here, this is the EEL dimensions, 4.3 by 4.1 millimeters. And the lumen itself is probably closer to 3.5 or so. And then IVUS run number 2, this is our LAD back to the left main. You see relatively undiseased proximal osteal LAD. There's this left main stenosis. And the left main itself gets pretty large in caliber. If you click on B1, this is our Prox LAD EEL dimensions about 4 to 4.4 millimeters. And then B2, this is our minimal luminal area. And then B3, this is the mid shaft of the left main, close to about 5.75.
All right, and we're going to show you our approach to DK crush. So we've pre-dilated, we've got wires there, and the first thing I'm going to do is I've got a 4015 balloon that I'm going to put for our crush balloon. That's sitting in the left main LAD, and we have a 3515 Zients that we're putting in the circumflex. It probably could accommodate a 4.0, but it's a distal edge that I'm not so happy putting a 4.0 in.
And the new Zions platform, the 3.5 and the 4.0 are the same stent, just different balloons, and they both post
Okay.
575.
Go negative. So let's see. Are you guys happy with that positioning? Give me a puff of the circ.
Yes.
I like it. Go ahead. So we're going to deploy the circ.
This is 12,
14,
14,
16,
16.
down.
Looks
Take
big.
a look at that pressure. We've got impella support. That's why we have impella support. So I'm going to let her pressure come up.
Pull this out.
Shami, why a 4.0 balloon? Why not a smaller one?
So I almost always size it because I want to crush that stent. And I think that's one of the things where if you want to crush the stent into that circumflex stent, if you use an undersized balloon, you're not going to quite do that. So the whole idea in the DK crush is we want to crush that stent. And then we're going to recross it. And so now, everybody has a different approach. Some people leave the wire in, some people don't. I tend to take the wire out of the circumflex at this point. And so the wire in the circ is out. And now there's my balloon that I'm going to use to crush. Give me just a puff. Okay, good. And go ahead. 8,
8,
10,
10,
12, 14.
And
Down.
that's a good technique, 1-to-1 size of this balloon, because otherwise you may get trouble getting the wire in if it's partially crushed.
Exactly. And so one other point I like to make, and I'm not even sure I got a good crush there, but I like to kind of run this balloon back and forth once I've done this crush before I'm going to go and recross. I'm going to do one more. I just noticed that she doesn't tolerate this inflation very well. So I'm going to wait a little bit, do one more inflation with a 4.0, and then we're going to recross. I'll take that run through, please.
But that segment that you're dilating here, you're going to cover completely with your other stent, right?
That is correct. Go up. So we're going up again. This is crushing the circ.
12, 14,
16,
16.
and down. So now we've got a wire down in the LAD. We have deployed the circ stent and we've crushed it. And now we're going to cross into the circ to do our first kiss of the DK crush. You guys are way too quiet.
So did you pull the balloon out, or you just parking it so we're going to use it for the kissing?
I always end up pulling it out, Gira, just because I find that it gets in my way. But certainly you could park it. So now,
You
Made
make it
look
look
too
so
easy
easy.
there.
well, it's
Maybe we
good
should
when
hook
you're
it up
live.
to the robot.
Okay, so now we have a wire down into the circ, and we still have the wire in the LED. I'll take a fresh 3515 NC emerge. So I'm going to do my first kiss with the NC emerge. I'm not sure it will cross, but I'm going to try. If it doesn't
What
cross,
size sham?
so I'm going to do a 3.5 NC in the circumflex, and I'm going to have a 4.0 left main to LAD.
You think it'll go down the circ, or you'll need a 2.0 or 2.5 balloon to help create that
Yeah,
channel?
great question. So we'll find out. It usually works in about half the cases.
Yeah.
So if the 3.5/15 does not go down, then I'll use a 1.5 or a 2.0 to create a channel. So
Shemi,
maybe you can talk about that, Rajiv.
Shemi,
Yes.
we have 8 minutes. Do you want me to ask Dr. Mahmoud to have an extension?
Oh, we're good. We have an extension.
Thank you.
But, you know, if he says no, just tell him it's his unlucky day.
This is the 3.5.
15.
We've still got about 20 minutes of IVAs coming up.
So,
Is this the NC Emerge or Euphora?
Before it.
So we have a 3.5/15 NC Euphora. It's a little stiffer balloon, but it's a little less compliant as well between the two. I think either work well. We'll find out if it crosses. Look
Shami,
at that.
if you
Wow.
I said today's my lucky day.
Shami, if
Okay,
you
we'll
couldn't
take a
cross,
4.050.
if you couldn't get
I'm sorry?
if you couldn't cross with a run-through wire, what's your escalation process?
4 or 15.
Would you go to
15
Whisper or-
15 actually.
BMW.
No.
BMW, which is my favorite wire. I don't care people who don't like it. Actually, I shouldn't say that. Dr. Patel doesn't like it. He can still hear me, and then he's going to say something about it. So I would go run through BMW. If it doesn't work, then Whisper.
It'll be fine, yeah, 'cause
And
we're-
then we've got all these fancy new wires.
Those CTO
Geon
things.
Black would probably be the one I would follow with. And then I think often what I find is I can get the balloon, I can get the wire down, but then sometimes I can't get a balloon down. So that's the real question. And I usually pick like a 1.5 balloon and see if I can cross it with a 1.5.
And if that doesn't go, we have also now the 1.0 balloon, the Sapphire. The 1.0 balloon, they're much more crossable than other
That's
balloons.
a great balloon, by the way.
They're a good balloon. They,
Saved me a
they
lot of time.
just tend to burst if they go too high in the pressure. Another option is if that doesn't go, can take a turnpike mini catheter and can just like kind of screw it in, and it's delayed because it's a taper, so it's a long taper.
So again, our goal here is to get a good result with our first kiss.
Circ, LED.
So this is the first kiss of the DK crush.
Circ.
All right,
LED circ.
okay, go up with the circ. So we're going to do the circ first. 8,
12,
10, 12, 14,
14,
16, down. So we went up on the circ to 16. We're now going to go up on the LAD.
Nice expansion.
Pressure. Pressure.
Again, she doesn't really like that, so I'm going to let this pressure recover, and then we're going to do a quick kiss. That was just sequential inflations.
I just think you have two large balloons in there. That's why the pressure is probably down.
Yeah, that doesn't help either. Agreed. I don't want to have the balloons too far down the LAD either.
And you do have a 6.0 left main, right?
Yes, in the
terms of-
proximal part. Okay, you have, I have LAD.
Yep.
Ready?
Together.
2,
2,
4,
4,
6,
6,
8.
8.
Down. What do you guys think of that? Should we do a more aggressive crush?
No, it looks good. We're waiting for the second stent.
Please don't.
Okay.
This Tim's talk on complications is coming up soon. We got to learn from him first.
So what stent do you take now for the LED?
What do you guys think? I'll tell you my thoughts once you just,
Yeah, IVUS was
Guys, tell me
4.0, right?
Well, it's got to be the 575, right? The Zions. Because you got to oppose it in the left main, right?
yep, gotta oppose it in the left main.
So probably you're at a 4.0 Zions, right?
4.0 Zions. That's what we were thinking. I want to take just a quick little puff, make sure we don't have a big dissection. Do we have a dissection? Puff again, please.
No.
No, we're good.
We have a
So
team-
we're thinking of a 4.018 Zions, but you know what? Let's take a picture and make sure everybody agrees with that approach.
Yeah, that should cover very nicely.
I think even more than 18, my friend.
That's the question, Rajiv. So you see where we're at. I wanted at least 8 to 10 millimeters in the left main. And my thought was it's not much beyond that, but there's no harm in going with a 23. It gives us lots of coverage.
Well, you have the
4.023.
balloon picture, right, from before? That was 15. So if you look at the previous
back one.
picture, it would help you size the length.
Yeah, and I'm also looking at just the LAD ostium, and it looks a little hazy there. So I think 4.023 Zions, please.
Yeah.
You guys see that little spot? I'm not sure that's the 4.0 balloon that caused a disruption.
it's
but,
dissection.
You can see the flow going slow in the
What's that?
in the middle.
I think it's a dissection in the ostium of the LAD.
I agree. That's what it looks like. It's filling. And so to cover that, we'll go with the 4.023, and that'll give us plenty of room on both ends. So there it is. So for the audience, you saw what we did is we stented the circumflex ostium, crushed that stent, recrossed and did the first kiss, and now we're going to put a stent 4.023 in the LAD and back to the mid shaft of the left main. And after that's done, we will pot the left main, get that optimized, and then we'll work on recrossing into the circ to finish with a final kiss.
And you know, that's such an important point, Shami, because after you pot, you take an angiogram, it's going to look great, and some people will say just stop, but you must do the second kiss.
Say, Shami, was that distal LAD that diffusely diseased before or is that different now?
No, it was always that diffusely diseased, Tim, and that was one of the reasons she was felt not to be a great surgical candidate. Puff that. I'm going to go in
looks
just a
good.
hair. Puff again. What do you guys think right about there? Puff. I like that. Go ahead. So now this is the 4.023 and 12.
12.
And if
14,
it's unclear if you actually
Yeah.
track the entire dissection in DLAD, you're going to IVUS that at some point anyway, so you'll be able to assess the vessel beyond the distal stent edge.
Now, you left your other wire down there, huh?
I did. This part I worry a little less about because I thought I had a pretty good channel and it's a run-through. But yeah,
But it is through, it's metal on metal, huh?
it's metal on metal because now we've got, I will pull it before I pot it though.
Yeah.
I don't think I've done this many times. I've never had a problem bringing the wire out, even metal on metal.
So looking at this, I'm pretty happy with the distal left main. It's all stented. You can see that the part of the stent that we just put in that's in the LAD looks well opposed. At the very ostium and where the distal left main is, it is unlikely to be well opposed. So the next step is going to be pot, and we are really not going to reuse this wire, so I feel comfortable doing the pot with the wire out. So we'll take, so what should we pot with, 5.0 or 4.5?
5-0.
5.
508 NC emerge, please.
Isn't your left main 6?
It's about 5.5,
Okay.
so I'm going to go with a 5.0 high pressure.
Shami, the distal LED is vasoconstricted. I mean, it looks smaller. You ever give drugs now? Vasodilatory
We
drugs?
could. You guys are worrying me. Give me a little puff. I didn't even pay attention to this LED.
Blood pressure is so good, you can give some
Maybe
nitro.
wire induced as well. Yep.
Yeah, so let's, we're waiting for that 508 NC. Where's my control? I want to look at the original.
Kind of started like that.
So as we were waiting for the pot balloon,
Did you pull that circ wire yet?
yeah, the circ wire is pulled. There was no resistance. It came easy. So there's what that LED looked like before we put a wire down it. But we'll give some vasodilators. Let me just pot and then recross so that we can get ourselves close to being done here. Go negative.
Or negative.
Okay, ready? Puff me, Lawrence. Go ahead, go up there to about 4, 6,
There's 4, 6.
down. Go to fluoroflavor 3.
3.
So since you used a 5.0 balloon, would you have gone higher
Yeah, puff,
than 6?
puff. I'm gonna go way high, yeah, go up. No, so I used the 5.0 where I was sort of extending into the LAD,
Okay,
8, 10, 12.
Oh. It slipped.
Okay. No, for sure, Rajiv, we're gonna go and take it at least nominal, if not bigger. Okay. Puff that. Good.
Let me try again.
Yeah.
6, 8, 10.
Yeah, it says distal edge.
Check on her, she's moving.
Yeah.
Shemi, can you take a picture? We don't sure about the distal edge of the stent.
Yeah, I'll take a picture in a second. I think it's fine. It's a little bit of contrast hang up.
Maybe.
Oh, yeah, you're right.
It's an extension of dissection.
Yeah, that original dissection, so.
Maybe the him.
Yes.
Yeah, we're working, ma'am.
ST changes too.
That was a 4.0 stent, so you want something,
I'm gonna take
a
a,
3.5 that would grow? Where's that bifurcation there?
Yeah.
Can you do a cranial shot?
yeah, we'll take a 3, 5, 12. Let's go AP cranial. Get me a 3, 5, 15.
I think longer than 12, Shami.
Yeah, no, I said 15. Let's take a picture here and we'll
You
decide.
might get a wire down your diagonal too.
Puff?
Well, let's.
Yeah. I got it. Yeah, I know, ma'am. Okay.
Yeah. Do you want to to protect this large diagonal? It's a huge diagonal. If you can, if it will.
I would stent and just rescue as necessary.
Let's
Right
open
now,
it
just
first.
get
Yeah.
stent in.
Get me a 3.0 18 Zions, please.
Yeah, 3.0
Actually,
looks
make it
better.
a 3.0 20 synergy.
Yeah.
Hang tight, ma'am.
3020 Synergy, please.
Coming up.
Yeah, we're almost done. Guys, do you
Certainly
have a
this,
30 stent of
this
any
shows the
type?
benefit of the Impella.
Well, the Impella is helping her a lot.
23 science. Here we
Yeah.
go.
We have a 3023 science, if not. What is this?
No,
Go.
You're good.
3020 synergy.
take it. Come on, guys. Just 1 second. I know you are. I just have one more stent to put in. So,
Gotta stop, I can't do it, it hurts everywhere right now, I got down here. I will be right now.
and give 25 of fentanyl, please.
Yeah. 18, do you have an 18, Shammy? I mean, anything beyond the diag's probably good enough.
Yeah, we got a 3020.
You got that.
Ma'am, hands down.
And I hope you guys keep it.
Puff.
I can't. it
Good.
hurts too
Wait.
much. I can't, it
Puff
hurts
again.
too much.
Go ahead, go up.
4, 6.
8, 10, 12,
We're almost done. We're almost done.
and down.
Almost done, it's been staying for hours.
I know.
You gotta just move over.
Puff. Good.
You should be feeling better, ma'am.
So we're gonna just let this sit for a little bit, then we'll do a post-dill of this to optimize it.
And you probably need a 4.0, right? Looks great there.
Yeah, I think what we're gonna do is IVUS, and then I think you're right, Bill, on the overlap for sure. And then beyond the overlap, we'll optimize and make sure there's nothing else we need to do.
Still for the 4, all right?
Okay, so what we're gonna do here is we're just gonna let her rest a little bit. And then we're going to dilate up in this synergy that we just put in at that overlap segment. And then we'll go ahead and recross the circ to finish with our DK crush, and then we'll do IVUS. So go ahead, get me a 3.5 15 NC balloon, please.
Well, that's a good example of the first miracle of stenting was avoiding abrupt closure due to resection. You know, all the restenosis came later, but that GR2 stent, I remember that in the early days, because I also remember the pre-stent era where you would just have to do the stack balloon, prolonged inflations.
Perfusion balloons, remember?
Those
Yeah.
patients went to the OR.
Yeah,
11%
and
did.
that's why we had emergency backup for.
But you know what the
cases.
GR2's name, right? Was guaranteed restenosis.
Let's ask a question. How many in the audience know what a stack balloon is? There's only like about 2 or 3 hands, Shami.
Huh. Well, I think the other point
The
here-
others are lucky not to know what it is.
Yeah, most people should be glad they don't know what it is. You got wire?
Absolutely.
Okay.
20-minute inflation,
Okay.
and then you let it down and you go, let's do another 20 minutes.
Actually, there's times where an auto-perfusion balloon would still be helpful, really.
Pan up a little bit.
And attending will leave the room and have a cup of coffee while you stand there as a fellow.
We have an aortic perfusion balloon now.
Just puff.
So what about the ostium of the diagonal? Are you going to look at that or not, or just
You know,
wait for another
what
time?
I'm going to do, Tim, is let me get this optimized here. Go up. And then I'm going to recross into the circ and finish my DK.
8.
10, 12,
Symmetry flow
14,
there.
16. Down. Okay, so So I'm going to finish with that DK crush, then we'll go ahead and IVUS. And once we have IVUS both the LAD and CIRC, make sure there's nothing else that needs to be done. At that point, we'll evaluate the diag. My take on the diag is that it's TIMI-3 flow. It's a pretty well-described angiographic phenomenon. Let's go back one. So let's look at this. It's a big diag, no doubt. And there are data that you can recross this and FFR it and determine and based on FFR if there's a problem.
It may
So
be
we'll,
just a metal artifact and this TIMI-3 flow. I wouldn't worry about that.
I would agree.
Or EKG's
So our
fine,
next
no
steps
chest
are,
pain, stop.
yeah, no, things are looking great. So what we're going to do next is cross into the CIRC and finish with our DK, second part of the DK crush. So they're ready for final pictures in the first room. So we'll go to room 1 and then we'll come back. All right, so let me just show you guys where we're at. So we gave some nitro. We think that's pseudostenosis about halfway down the LAD. We're going to IVUS that in a second. Let me show you the next thing we did. Here is a fluorostore of the wire down into the CIRC. That's the wire in the CIRC. And there's a balloon in the LAD. And here's the balloon coming into the CIRC. And that's where we're at right now. We've got both balloons in position. And let's see, Lawrence, you go up first with the CIRC. These are both 3 5s. Just go to 2, 4, 6, 8,
Yep.
10, 12.
Yep.
Down. So that's 12 on the CIRC. I'm going to do 12 on the LAD. Okay, we're just going to go to 6 on both. Ready?
Yep. Starting at
This is
2.
both simultaneous. Okay.
Yep.
Down. 8 on both and down. Just a little puff. Good.
Given her 200 mics at that moment.
And so we've done our second kiss. I'm now going to go ahead and pot at the end, the left main, and then we're done. Then the only thing left to do is a final IVUS. Let us finish the pot. We'll take an angio, and then I know we're running late. So what we'll do is go ahead and get me that 5-0 for the final pot. So we're going to go with the 5-0 balloon in the left main for the final pot. Then we'll do the angios, and then we will IVUS. Any questions, comments?
No, it looks really good. Do you want us to stay with you, or we can trust you that you'll do it even without us?
Why don't you stay with me till I've done the angios, Gira?
Okay.
That's it.
Let me pot, then we'll do the final angiograms, and then I know there's a final session that we still have to finish up. So what we'll do is show you the final angiograms. The only thing left at that point is our IVUS imaging, which we can do offline. And we can then go to finishing up the final session. I think the final session has Dr. Ang giving the first talk, but he's scrubbed here. So what
Maybe I
we'll
can catch you
do
at the,
is
back
maybe
wall.
after this, you guys can take a few minutes break or decide what you want to do. We'll have Dr. Ang move his talk to tomorrow.
Okay. So you're going to start with Ziad's talk?
Yes.
Yeah. Okay.
Hold on. Let's get a fresh one. Fresh 508.
508.
Swipe it. Good.
So Gira, you picked up that distal edge dissection. What's interesting is I was just reviewing it offline, that after the initial placement of the stent, it was fine, and it probably occurred with the post-dill.
Yeah, it might be a hematoma that was pushed by the post-dill balloon that was pushed down.
Yeah, so let's see, it's all kind of, because here's our initial deployment, and things look pretty good there.
I agree. I think most probably the mechanism was that we saw something. We saw some haziness, right? Immediately distal to the ostium, and we said it may be a
There.
dissection.
Yeah,
That-
it did look like
Yeah.
a
Right.
linear.
So it was a hematoma there that was actually pushed down by the post-dilatation balloon.
Likely one in the pushed from, remember when I was doing that 5-0 inflation in the left main, it was extended into
Right.
the LAD at 6 atmospheres when Rajiv actually said you're doing this at 6, and I think that might have been the time. But anyhow, here we are. I do think this pot is a very important final pot. Give me a puff there. But I'm going to make sure I'm well in the left main for the final pot before we IVUS. So go ahead and go up, please.
And I think, Shami, for an education tip is that once you see that dissection, like what you did, like, you know,
10,
by minimizing
12.
injections, because you could propagate
Yeah.
that dissection distal.
Absolutely agree, Rajiv. And I think part of it is to, once you've identified the problem, get it addressed and covered as fast as you can.
Yeah. But it's surprising. I mean, even though the 5-0, you were quite a ways away from the end of that stint. And it's a little surprising that you'd close, but it shows you, it's a perfect example of why we have to answer this question about support or not support during high-risk PCI. Because I think if you would have not had the impella in, this might have been gone so well.
No question. So I'm pretty happy with this final result. We're going to obviously IVUS, and then we will evaluate anything else. Any other comments, thoughts?
Great job.
No, it was very educational case. Thank you, Sam.
And I agree, Tim, that it highlights having hemodynamic support. We did a long 2-stent mid-RCA. We did the distal left main, LAD, circ, and when there was an edge issue, we had the hemodynamic support necessary for us to get ourselves out of that problem.
Yeah, that was
All
really
right,
great.
thanks, everybody. I will see
Yeah.
you a
Okay.
little bit on site in just a bit here.